You probably heard that multiple myeloma survival, and this is a slide that has been shown before. And we have long-term remissions. We do have patients that maintain these remissions for 10 plus years. And the unmet need in multiple myeloma, or the future really, will focus, as mentioned before by Ivan and David, on those high-risk patients, those 25% of the patient that, even with the new developments, they don't have a median survival of 3 years. This is a group that we need to focus on. These are weeds, and I think to be able to describe multiple myeloma, and I take that from Ivan's friend in Hopkins, Rick Jones, who always described treating myeloma like removing weeds. In the beginning, you actually cannot tell if you have weeds in the yard or not. Like now is the spring, you don't really see, they are all green. After a while, you start realizing them. And I think in myeloma, the future really will be try to have a better detection for those weeds. Probably introducing early therapy, and I think we heard a lot of trials starting in smoldering myeloma, and I will share with you some of the trials we have. Again, there is this tumor-directed therapy, and I think that's clearly specified by stuff like Ivan is doing, immune therapy, or other immune therapy trials like the daratumumab. And really, the biggest issue that everybody is struggling with is this bone marrow microenvironment. You can keep treating the myeloma, but if you don't change the bone marrow microenvironment where this myeloma lives, you probably end up with myeloma coming back. You might delay the recurrence, but until the soil, this seed and soil concept, you can keep killing the seeds. But if the soil is still accepting fertility and can grow seeds, you will end up with relapsed myeloma. I think the concept of MRD has been mentioned many times, and I just will emphasize quickly that MRD is important in myeloma. It has been associated with improvement, as you can see, in progression-free survival and also overall survival. The trials that we heard about that take 7 to 10 years to have an answer, I think nowadays we are moving a little bit the pendulum to the other side. And as you don't know, probably MRD, or minimal residual disease, is going to be an acceptable endpoint for assessment of myeloma therapy. Meaning we can look at treatments and we can say, okay, if MRD is negative, this treatment is effective in myeloma because it translates into improvement in overall survival. And the FDA, I think, is going to accept MRD as a measure of disease with all the problems of MRD. That's not the answer, but it's definitely going to be one of the endpoints that a lot of clinical trials will be looking into. At this point, by the way, you can get MRD negativity. It's not advisable. Most of what we do is MRD is done on clinical trials. Imaging in multiple myeloma, I think, has been mentioned multiple times, and I just put that in for one reason, because MRD negativity doesn't mean that you don't have myeloma. There is a subset of patients that you have MRD negativity, and you do PET scan on them, and you find tumors. And a lot of work has been done at the University of Arkansas that they do PET scan on patients every 6 months. They do bone marrows frequently, and it's not unusual to have an MRD negative patient with positive PET scan, and the biopsy showed that this is positive. Probably the newest test in the future, I think it will replace skeletal survey and will replace MRIs and PET scans, is what's called low-density whole-body CT scan. And this is a very easy test. It takes 5 minutes. It looks at all the bones. And actually, more importantly, it delivers the lowest dose of radiation you can get. The test can be done in a lot of places. The problem with it doesn't have a code. It doesn't have ICD code, so they cannot bill for it. And that's why a lot of centers, no, that's true actually. It took us a long time to be able to get our certain code to be able to bill. And once we did that, patients are actually getting low-density whole-body CT scan. I think we discussed the definition of CR, and I think the future is clear. Initial CR was negative immunofixation and bone marrow less than 5%. Now we talk about stringent CR when we introduced the free light chains. We heard about MRD negativity. And I think negative imaging need to be in the equation because you look at the bone marrow at a molecular level, but also you need to look outside the bone marrow. So you really need to look at both. And there is data, I'm not going to show you the slides, but if you actually have PET scan negativity, MRD negativity, you do have the best outcomes. And this is development. Just to summarize this part, I think the next generation protocols in the future will be looking at treatment to MRD negativity. And actually that's what we're trying to develop with other colleagues is, can we have a protocol and then look at MRD negativity? And once we have 2 negative MRD, can we make a decision on treatment? Do you need to randomize patients to maintenance or no maintenance? And what to do with the disease outside the bone marrow? And I think once we have that, that will be a huge benefit for all of you because nobody wants to be in treatment forever. And I think once we have a marker that correlates with survival that can be used effectively, that will be, I think, a huge benefit. And I think that's the next wave of therapies that I'm hoping we will see something soon there. The second area in the future in myeloma is actually early intervention. And I know that this concept probably doesn't apply to most of you, but we described before this heterogeneity in multiple myeloma. In MGUS stage and early stages, we have many clones of disease, meaning we have many clones of myeloma cells. Each one of them has a very different characteristics and different mutations. And the question is, can we treat early and take advantage of early intervention with the goal of either prolonging remission duration or curing multiple myeloma? This is the classic, what we heard about MGUS. It's very small cells. M spike is usually very low. Plasma cells are less than 10%. Smoldering myeloma is a little bit more disease burden, but no symptoms. Once we start having symptoms, that becomes multiple myeloma. And you probably know a couple of years ago, very high-risk myeloma was moved to myeloma. Smoldering myeloma moved to myeloma if they have bone marrow less than 60%, light chain is over 100, and focal lesion on MRI. None of those represent symptoms, but the risk of progression to those patients was very high, and that's why they were considered multiple myeloma, and today we treat them as we treat multiple myeloma. So we ended up with this group of patients that I think Ivan showed this slide multiple times, showing this slanting progression, those 10% of the patient that progress within the first 5 years. Some interventions, including lenalidomide, have shown that if you treat patients with lenalidomide in a smoldering stage in a randomized fashions, you can prolong the time to progression and you improve overall survival. And the data is very preliminary. It was done on 90 patients, so it's not enough to consider the standard of care, but it definitely gives a signal that if you try treating multiple myeloma, you might actually have benefit. The problem with those trials is they are the observation arm in Europe. This was a Spanish study. They didn't do anything for the patients. They actually put them in observation, and their kidney function started getting worse. The creatinine goes from 1 to 1.5. They do nothing because the definition of renal insufficiency is 2. And the patient complains of aches and pains. X-rays are done very infrequently. So we ended up in the observation arm with some serious problems, like some patients ended up with renal failure, some patients ended up with fractures. That's not how we follow smoldering myeloma patient in this country. And definitely we intervene early if there is any signal of abnormality. The goal of this trial was to delay progression. And I think once this trial succeeded, there was a very ambitious approach. Can we actually cure multiple myeloma at that stage? And there was a very small trial looking at 3 drugs, Carfilzomib, Lenalidomide, and Dex. This was an NIH trial by Ola Lengren. And he actually treated patients with very intensive regimen. This is a regimen we give to myeloma patients. And he showed that actually you achieve a complete remission. Not only stabilize the disease, but all those 12 patients achieved a complete remission. He collected stem cells on them and decided to monitor them and see what happens. He published this data. I'm aware of one patient has relapsed and he came to us for transplant because the program in NIH is closed now. But the rest of the patients appears to be actually in a stable remission at this point. So it looks like this very intensive intervention early on has benefit. And I think was mentioned earlier that there is about 17 trials for multiple myeloma, for smoldering multiple myeloma. We had one of those trials looking at Elotuzumab and Lenalidomide and Dex. This trial was a national trial of 5 centers. The lead on it was Irene Gabriel, and we enrolled about 7, 8 patients on it. Some of you are on this trial. And this trial actually treated patients as if you treat multiple myeloma. Elotuzumab is a monoclonal antibody and actually have some immune properties, including stimulating some NK cells. And lenalidomide, we know its effect. We chose high-risk patients. And actually, the trial was promising because we ended up with complete remission in a small subset of patients, very good partial remission in about 26%. And almost all the patients are actually doing quite well at this point. The only observation that we worried about when we did this trial, and I don't have slides here, I didn't really want to overwhelm the story, but there is this concept that if we are describing 7 clones of multiple, of different cells in a myeloma patient, some of those clones are very aggressive and some are less aggressive. What happens if you take the less aggressive clone out? Well, the more aggressive clone takes off and you end up with an aggressive myeloma. And actually in this particular trial, there are some indication that that can happen. We have 2 patients, one in here and one in Maryland and one at Dana-Farber, had a very nice response, while during the observation period, repeat bone marrow showed that they started to have deletion 17 myeloma. And those patients, we treated them with intensive regimen, did transplant on them, and we are monitoring them to see what will happen. But treating smoldering myeloma has to be done only in clinical protocol because of that approach. And the concept is, because it's an easy disease, we can use an easy treatment. It's definitely there if your plan is to delay the progression. But if your goal is to try to cure the myeloma, we're realizing that you probably need to be more aggressive. And because of that, we are part of the, someone asked me, is there any smoldering trials in the area? Yes, we do have this trial that actually is about to open. It's delayed by the FDA. They have some questions. The trial is very aggressive regimen. As you can see, it includes induction with 4 drugs, Carfilzomib, Lenalidomide, Daratumumab, and Dex, followed by transplant or consolidation, followed by intensification and maintenance. So it's a very intensive regimen for about 1.5 years. And the goal of this trial, as you see in the title, it's a curative approach. And the goal of it is to try to kill those different clones using different regimens and different drugs that can actually cure multiple myeloma. And I think this is going to probably be the next wave of myeloma treatments that we're going to be focused. And it's paradigm shift. In an easy disease, you are giving very intensive treatment rather than leaving your intensive treatment for later times. Just one of the few promising drugs, and I chose 3, and I just chose them because I guess I like them. And we are part of some of those trials. But definitely there is more trials ongoing and more results if anybody is interested. But I think the most exciting drug that's not approved by the FDA yet is the venetoclax. This is a BCL2 inhibitor and has been approved for treatment of CLL, and actually changed the landscape for CLL. I think you can look at CLL at this point as we look at a chronic disease that you probably can maintain remissions for a very long time. And this is a monotherapy trial that was done in myeloma. The first columns are all the patients on the trial. And you can see there are overall response was 21%. Anything over 20% is exciting, but what was interesting in this trial, first they have very high number of patients with translocation 11, 14, and 30 patients. And then all of a sudden we see impressive responses in those subset of patients, including complete responses and stringent complete responses. Why? It's probably related to the fact that 11, 14 translocation patients are having high level of expression of BCL2. And this area has always been a focus for myeloma treatment. Actually, years ago, probably, if I remember, the Genasense drug, which actually we have done a trial in Maryland using Denachance as an antibody against BCL2 in combination with thalidomide and Dex, and it didn't really result in significant outcomes. But it is clear at this point that this is a target that we are after. There is more trials looking at MCL1, which is a broader target rather than BCL1, and there is more impressive data presented actually in ASH this year, looking at combination of Velcade and venetoclax, and you can look at patients that have prior Velcade, overall response of 89%, and good number of patients achieving stringent CR. So this will be probably, if the concept succeeds and we have this impressive responses in 1114, it will be one of the first times that we can look at the FISH or cytogenetic profile and say, oh, you have 1114, maybe venetoclax should be in the treatment schema for you. I just want also to mention that 1114 translocation is the most common translocation in primary plasma cell leukemia and occurs in about 60%. And we are part of a group that will open a trial looking at plasma cell leukemia patients with venetoclax, carfilzomib, and pomalidomide as induction treatment, and then hopefully transplant after that. So this is one drug that's actually currently in advanced stages, and I believe it has received the accelerated approval from the FDA. The second drug that I think is good is selective inhibitors of nuclear transport, and actually this drug is called Selinexor. You probably read about it a lot, and this is data presented as well this year, looking at combination in relapsed refractory patients. And as you can see, overall response is what we always look at, partial response or better, so it's actually not bad. It's about 20%. As I mentioned, anything above 20% as a single agent in refractory relapsed myeloma is acceptable. And when this patients, you can look, some of them are actually pentarefractory, and you can see that those patients, as time go by and they stay longer in remission, they can maintain this remission. There are some randomized, actually combination trial. I believe Hopkins have a trial with Carfilzomib. Is that correct? Velcade. And there is now also drug receiving accelerated approval. So there's going to be a randomized trial starting looking at Selinexor plus Velcade and Dex, and that will hopefully result in approval of a new class of drugs. It's promising. It doesn't mean that you should go on that, but it's definitely something we can look at. Antibody therapy in myeloma is a huge area at this point. You probably all know the data about daratumumab. I will not show it, and I will not show any data about pembrolizumab after the disappointing slap by the FDA to FUMAR trial, so I will not talk about that. But I will mention the what's called BITE technology. This is a new class of drugs that actually targets BCMA. And BCMA is a very, as we heard from Ivan, very important target in myeloma cells in late stages. This is a new antibody that attaches to the target, BCMA, but then it releases toxins, antitubulin toxins, to kill the myeloma cells. So it kills it like in a double way, because once you attach to the BCMA, there is some killing that occurs, but then you release directly into the cell a toxin that can further kill the cell. And the results were very impressive. That was another presentation in ASH this year, our American Society of Hematology. They treated 36 patients. Those were really heavily pretreated patients. And you can see the overall response was about 60% with some CRs and VGPRs. This is overall survival there. So it's definitely a very impressive target. CAR T cells, we heard about it. I will not talk about that, but I will talk about the responses. This is what Ivan mentioned. You have a patient with a packed bone marrow at baseline. Day 14, the bone marrow is clean. 3 months later, it's still clean. PET scan showing this, completely resolved within 6 months, or within 1 month, you start to see responses. So they're very effective treatments. And I think we will probably have a trial. I know that people here are asking, are you having a trial for for CAR T cells? I know that Hopkins will have a trial for BCMA opened, and we will have another trial. Our trial is one that's mentioned, the Bluebird with Celgene. We'll have this trial for patients. It is a randomized trial enrolling patients between CAR T cells or daratumumab, pomalidomide, and Dex. I know that randomized trials are very difficult for most of you to accept, in addition to the fact that it's a trial. You get randomized, so you don't know if you will get the CAR T cells or not. But unfortunately, that's going to be the only way to establish efficacy and durability of responses, which is very important target. As time goes by, myeloma patients are living longer and longer, and we are seeing some new side effects from the treatment. One of those side effects that we started to see is called CNS myeloma. And it is something I just will mention because it is, at least in our center, in the last 5 years, we have seen about 20 cases. In the last 6 months, we have seen about 3. The first case, patient came and said, I have this numb chin. And quickly they start having headaches, blurred vision. And those patients, we usually try to do CT scan and we do a lumbar puncture. And that's how we diagnose CNS myeloma. This was a disease that unfortunately there is no good outcome for it. Once you get CNS myeloma, there is really no treatment. We give intrathecal chemotherapy with no outcome. About 3 years ago, we started doing a trial with a drug called Myeloma. Myeloma is a third-generation proteasome inhibitors. It includes very similar to Velcade, Carfilzomib, but it is different because it crosses the blood-brain barrier. And while we are doing the myeloma trial, actually we just published the results combining Myeloma with pomalidomide and Dex, showing some activity and good outcomes. But they treated some glioma patient with CNS cancer. And surprisingly, those patients responded beautifully. So I ended up with a patient with CNS myeloma, and I decided to have what's called compassionate use to see if I can treat the CNS patient. And we actually published that this year, I think, just last year. And we treated this patient with leptomeningeal myeloma with this Myeloma. And to our surprise, 3 months later, the patient's symptoms improved. You can see the disease here. It's very difficult to see, but if this area, it clears. All these nodules in the brain have cleared after using Myeloma. And we are currently actually in negotiation with Celgene. We are going to open a national trial. It's very difficult to open one center trial with CNS myeloma because in our center, we see about 4 or 5 patients. So if you see a center sees about 200 myelomas a year, you will end up with 3 or 4 cases. So we're hoping to have a national trial, and we're going to combine this Myeloma treatment with Daratumumab, which also, by the way, crosses the blood-brain barrier, and pomalidomide. So this is, as we call, part of the success of the treatment. We have patients living 10, 15 years, and this is the sanctuary site, has always been a sanctuary site, and we started to pay attention to those areas. So this is the future, at least in a limited view from my center. And I think we are in an area, these are all the standard treatments for myeloma. Most of you had 1 or 2 or 3 or 4 lines of prior therapy. I am glad that there is a way for you now to figure out where can you get the next treatment. There are some protocols that allow patients after 1 line of therapy or after 2 lines of therapy, and there are some protocols like we heard from Ivan. You have to fail 5 lines of therapy, including all available drugs before you go on them, because they are very aggressive treatment. Just to answer the question that I know I'll be asked about immune therapy side effects, yes, we did the pomalidomide trial with this pembrolizumab, and I just want to say that we had request from the FDA to stop the trial. And the time I stopped the trial, there were 10 patients on the trial. All of them were in complete remission, including 3 patients that never achieved a complete remission, even with transplant, and they were in relapse setting. So I just want to emphasize that this treatment is effective. The mortality that occurred, and the reason the FDA jumped on all of that, is that the side effects are significant. When you unleash the immune system, as we say, and there is a very nice write-up in New England about a year ago about that, not New England, New York Times, equivalent to New England in its significance. The New York Times saying that a lot of emergency rooms are getting all those patients and they don't know what to do with them. They are coming in with shortness of breath. They develop pneumonitis. The T cells that we activate in vivo can attack different organs, including the lungs, including the heart and the liver. And I have to admit, our trial was very difficult to do because if it wasn't for research nurses, and actually some of them are here, They are picking all that stuff up. The patient coming in with shortness of breath, they do an EKG and they call me and tell me there is a regular heartbeat. And this patient has a troponin of 50. In a private setting in the community, this patient was ignored. And that's why I was against using this treatment in newly diagnosed patients. And also, not every new treatment everybody should get. Those treatments have side effects. And I think once the trial matured, we realized that there is benefit for subsets of patients, but the side effects need to be managed. Like the CAR T cells, we put patients in the hospital, we don't close the program. So I think the FDA just coming to their senses again, and they're going to open the trials with incremental approaches. This paper is published in Blood that we talked about with the pembrolizumab, and I focused most of my talk on the side effects, how we manage them, as well as the benefit, which the good news is when we stop the treatment on those 10 patients, some of them remain in remission 1 year out, which is a classic finding in immune therapy in solid tumors. You stop the treatment and the remission and the benefit persists. So this is the future as I think I see it, and I think that's my last slide.